travels.
Okay, let's break those down. First one.
Contact precautions. For germs spread by direct touch or indirect touch via contaminated surfaces, usually thinking within about, say, 3 feet. This means a private room is ideal, or you can cohort them, put patients with the same infection in the same room, and caregivers must wear gloves and a gown.
What germs are we talking about here?
Things like RSV, many wound infections, scabies, and if you have to move the patient, like for a test, any draining wounds need to be covered securely. Keep those germs contained.
Okay, next up.
Ever.
Droplet versus airborne. This always seems to trip people up, but it's all about particle size, isn't it?
Exactly. It's physics, basically. Droplet precautions are for pathogens spread in larger particles, bigger than 5 microns. Think of them like tiny water balloons. They're relatively heavy, travel maybe 3 to 6 feet, then drop pretty quickly. They don't hang in the air for long.
So if you're close, you just need a barrier.
Pretty much. A standard surgical mask, maybe a face shield if you're working within that 3 to 6 foot zone. Pathogens here. Influenza, meningitis, pertussis, whooping cough. The source actually had a handy mnemonic for this. Droplet. Think PMP. Pertussis, influenza, meningitis, pneumonia.
PMP. Got it. Okay, now contrast that with airborne. Much smaller particles.
Way smaller, less than 5 microns. These aren't water balloons. They're more like fine dust or smoke. They can travel much farther on air currents and stay suspended for ages. This means the entire room's air is potentially contaminated.
So a simple mask isn't enough.
No way. You need much more protection. An N95 respirator, which filters out those tiny particles. And crucially, the patient needs to be in a negative pressure room.
Explain that. A negative pressure room.
Yeah.
It sucks air in from the hallway, right? So contaminated air doesn't leak out.
That's exactly it. It contains the contaminated air and vents it safely outside, protecting everyone else in the facility. Airborne pathogens are the really serious ones for transmission. TB, measles, varicella chickenpox, and the mnemonic for this one. Airborne, think MTV. Measles, TB, varicella.
MTV. Okay, that helps. So we've got contact, droplet, airborne isolation. But there's one more environment that's the complete opposite, right? Protecting the patient from the environment.
Yes, the protective environment. This is for patients who are severely immunocompromised. Think stem cell transplant recipients, their immune system is wiped out. Here, you need a positive airflow room with HEPA filtration for all the air coming in.
So it constantly pushes clean, filtered air out into the hallway, keeping germs away from the vulnerable patient.
Yeah.
Like a protective bubble.
A bubble of safety, exactly. Now, we've talked a lot about the technical side, the masks, the rooms, the airflow.
But there's a human side to this isolation too, isn't there?
Absolutely. It's something easily overlooked. Being in isolation, especially for long periods, it takes a toll. Patients in isolation have a significantly higher risk of depression, loneliness, anxiety. It's psychologically very difficult.
Every time someone puts on gloves and a gown before entering, it's a reminder that you're seen as, well, as a risk, even though it's necessary.
Exactly. And the rules are strict, changing PPE after contact with each patient. It's vital for control, but it reinforces that barrier, that separation, over and over again.
Okay. We've covered the active defenses, the barriers, the isolation. Let's shift gears to the proactive side. Hygiene. This isn't just about looking clean, it's a fundamental defense. It promotes comfort, sure, boosts self-image, but critically, it decreases infection and disease.
Yeah, hygiene covers all those activities of daily living, or ADLs, bathing, oral care, grooming. And a person's ability or willingness to do these things depends on a lot of factors.
Like what sort of things?
Well, cultural and religious beliefs can play a big role. The example given was Orthodox Judaism, where personal care might be prohibited from someone of the opposite sex. You have to respect that. Economic status, too. Can they afford supplies? Do they even have access to, say, a shower?
And health status must be huge, especially cognitive or emotional issues.
Definitely. If someone has cognitive impairment, maybe from a stroke or dementia, they might not be able to figure out the steps for bathing or even recognize they need to bathe. They often need step-by-step guidance. And with emotional problems like severe depression, you often see a real lack of energy, just profound fatigue. This can lead to poor hygiene, not caring about appearance. The motivation just isn't there.
Physical limitations too, I imagine. Pain, being stuck in bed, sensory problems.
All of those make self-care much harder, yeah.
Let's get into some specifics from the source on high-risk hygiene tasks. The details matter hugely here. Oral care for someone unconscious.
Extremely important and high risk for aspiration breathing fluid into the lungs. The absolute key is positioning, side lying, always.
Why side lying specifically?
It lets saliva and any cleaning fluids pool in the cheek and drain out of the mouth instead of going down their throat. You also need suction ready, just in case.
And rules about what goes in the mouth?
Use a padded tongue depressor or a bite block to hold the mouth open safely. And never, ever put your fingers inside their mouth. That's a bite risk. Also, a very specific warning in the material. Do not use lemon glycerin swabs.
Really? Why
Right.
not those? They seem common.
They actually dry out the oral tissues, the mucosa, which makes it more prone to cracking and infection, totally counterproductive.
Good to know. Okay, what about denture care? Seems simple, but I bet there are pitfalls.
Main things. Store them in a labeled container with water or solution so they don't dry out. Clean them with tepid or warm water, not hot water can warp the plastic. And the big safety tip, put a washcloth in the bottom of the sink before you start cleaning them.
Ah, so if you drop them, they land on the soft cloth, not the hard sink.
Smart. Exactly. Prevents chipping or breaking. Then two other quick points. Shaving.
Right. What's the main concern there?
Assess the skin first. Look for any redness, lesions, moles. Don't shave over those areas. And if the patient is on blood thinners or has a bleeding disorder or even just a high infection risk, do not use a standard razor. Use an electric razor instead. Much lower risk of cuts.
Makes sense. And finally, diabetic foot and nail care always seems to come up as high risk.
It is. Because of potential nerve damage and poor circulation, diabetics are really prone to foot infections, and healing can be very slow. So the rule is, always check facility policy before trimming a diabetic patient's nails. Often, only a podiatrist is allowed to do it. It's that serious.
Okay, wow. We've covered a lot of ground. We started with those really sobering HAI statistics.
The 1 in 25 number, the deaths.
Yeah. Then we walked through the infection timeline, incubation, prodromal, all the way to convalescence, then the defenses. Standard precautions is the baseline.
Right, then layering on contact, droplet, airborne based on how things spread, remembering PMP and MTV.
And the opposite, the protective environment. Then we shifted to hygiene, why it matters, what affects it, and those really specific critical details for things like unconscious oral care or diabetic feet.
And connecting it back to you, the listener, I think the big takeaway is how much precision matters in all this. Knowing the difference between a droplet particle bigger than 5 microns and an airborne one smaller than 5 microns, that dictates whether you wear a simple mask or need an N95 and a whole negative pressure setup. Understanding these details is key for protecting yourself and others.
Definitely. Now, the source material mentioned that using PPE correctly includes both putting it on, donning, and taking it off, doffing. But it didn't list the steps for doffing, which leads to a final thought. If the whole point of PPE is to keep pathogens off you, what are the specific dangers when you take that gear off incorrectly? What goes wrong?
That's actually a critical point. Doffing taking PPE off is arguably the moment of highest risk for self-contamination. Think about it. The outside of your gown, your gloves, the front of your mask, it's all potentially covered in pathogens. If you touch the contaminated outside with your bare hands or move things in the wrong order, like if you pull off your mask before taking off your dirty gloves, you could easily transfer germs to your face. Or touching the contaminated gown front while removing it. That sequence, that procedure for taking it off safely is absolutely crucial. It requires real focus to avoid contaminating yourself right at the very end.